Good morning once again, everyone. Welcome to today's webinar, The Other Dementias, Frontotemporal, Lewy Body, and Vascular Dementia. And we're so thankful that you're here with us today. Our complimentary webinars are brought to you through a collaboration with O'Connor Mortuary, Care Choices Hospice and Palliative Services, Caring Companions at Home, and Chatterton and Associates, the Wealth Management Team. And of course, us here at Alzheimer's Orange County. My name is Melissa Klabe. I'm the Director of Education at Alzheimer's Orange County. And again, our sponsors are providing these webinars as a service to our community on topics beneficial for anyone who cares for or works with older adults. And we do hope that you find them informative and useful. We are so pleased to have our own Kim Bailey with us today to present on the other dementias. And before I introduce Kim, I just want to thank our sponsors one more time: Chatterton and Associates, O'Connor Mortuary, Care Choices Hospice and Palliative Services, and Caring Companions at Home. And so today's presenter is the wonderful Kim Bailey, who I have the pleasure of working with. She's worked in the field of gerontology as a lecturer and a professional for 30 years. She holds a Master's of Science in Gerontology and a BA in Sociology, both from Cal State University, Fullerton. Ms. Bailey is the Programs and Education Specialist here at Alzheimer's Orange County, where she is responsible for developing and presenting programs and education for families and professionals throughout our community. And additionally, she works within our social engagement programs and early stage programs offered for people with memory loss and their care partners. And she coordinates our organization's education and support programs for individuals and families living with intellectual disabilities and Alzheimer's disease. And so it's my great pleasure to turn you over to Ms. Kim Bailey. And she's on screen.
Hi, everybody. I thought we thought we'd try an experiment today. I wanted to share my webcam with you. It feels like we're also isolated in this time of COVID. I actually wanted Melissa to turn her camera on too, but we had some technical difficulties. I do want to invite you, Melissa, to dialogue with me during the discussion today. Have it be less of a lecture and more of a dialogue, because Dr. Glabe is our Director of Education. She's very well versed in the topic. And so I invite you to kind of stay with me, Melissa, as we go through the PowerPoint, and chime in whenever you want. And actually, I need to minimize this a little bit. Let me see if I can do that. Yeah, there we go. As we explore this topic of the other dementias. And so one of the things that I was chatting with Melissa about before we got going this morning is the fact that so many of you online with us today are working in the provider field. And as you bring a new client on service, whether it be for in-home care or in the care industry with your care communities or hospice, what have you, oftentimes the diagnosis just says dementia. And so you don't know if you're dealing with Alzheimer's or Lewy Body or frontotemporal or FTD, et cetera. And so the information that we are going to share with you today was really part of a presentation, a lot of information that was shared to us by our good friend, Dr. Kent Papard, who is a licensed clinical psychologist here in Orange County, great friend of Alzheimer's Orange County and the community. And the information was disseminated to us in a lay format, so that it's non-scientific and really easy to understand. And I think that's what we all need. And at the end of the lecture today, I think what our goal is for you to be able to look at clients in a different way and to understand that while all dementias are progressive and degenerative in nature, and they all involve, memory and problems with thinking and judgment and behavior, etc., there are some distinct characteristics in some of these other dementias that stand out. And so even a lay person like, you know, you and I can look at people and sort of understand that they may have a dementia other than Alzheimer's disease and that they require special treatment. And so that's just sort of my agenda, our agenda today. But before we dive in, let's just sort of look at a snapshot of our aging population. So looking back in 1900, the average life expectancy for a person living in our country was 47.3 years of age. And now, of course, you know, we're all living a lot longer. And of course, think about age as the #1 risk factor for developing dementia and mild cognitive impairment. And I think most of us understand that MCI, or mild cognitive impairment, one way to think about it is that it's sort of the preclinical stage for Alzheimer's disease. And I'll talk more about that in just a moment. Alzheimer's disease and Lewy body typically begin after the age of 65. But we'll learn today, if you don't know already, that a disease like frontotemporal dementia typically develops between 45 and 65 years of age. So that's got a young onset, and that fools people, even community physicians. So, you know, I've been in the Alzheimer field for 30 years, and I know that early on, a lot of folks with FTD were misdiagnosed, and they continue to be misdiagnosed because you don't typically look at a 45-year-old who's behaving in a different way and think, oh, they probably have some type of dementia. And that's the case even with folks with Lewy body. We know a lot of our clients have been misdiagnosed and, you know, mistreated in many regards. And so the information that we share today, I hope you'll have a much better understanding as we go along, and that this will help enhance your knowledge of these different dementias. Every day in this country, approximately 10,000 people turn 65, and about 54,000 Americans are 100 years of age or older. So all of us here that work in the field know that for many years now, we've been experiencing what we call the grain of America. And more of us are called to serve this population. And we thank you at Alzheimer's Orange County for all you're doing to serve older adults, particularly of late during this time of COVID. And it's not been easy. So we thank you for the great job that you're doing. And if you look at folks that have been involved in the journey of dementia, you know, you recognize and know that it's been a very long journey indeed, because people start, you know, sort of at the top functioning level, and they're experiencing what we might call successful aging, and they're just seeing maybe some normal age-related cognitive decline, but then gradually we start to notice some slippage, or maybe others don't notice it, but they notice it, and they sort of slip into this phase that we call mild cognitive impairment, or MCI. And that's a zone that, you know, it's almost like a waiting room for dementia. And it's during that time that changes are happening in the brain that aren't really playing themselves out. They're not noticeable in day-to-day living. So people are still maybe driving, they're still working, but the changes are severe enough to show up on testing. And then, you know, people don't all necessarily go on to develop dementia, but people are at very high risk for developing dementia. And in fact, we see many folks gradually over time descend into more signs, more changes, more brain changes that signal dementia. And then once people have dementia, we're seeing more and more changes that are becoming more noticeable to themselves and to their loved ones. And then over time, the symptoms go from mild to, over the years, moderate, and then severe. So you see, this is just like a slow, steady, decline that takes place. In most cases, in the absence of other diseases, it can take place over quite a few years. So that's just a little bit about the continuum of change that can occur with adults that are on the journey of dementia.
Kim, I wanted to jump in real quick if I could on that one slide and mention one other kind of stage that is sometimes talked about in between normal age-related changes and MCI, which is subjective cognitive decline, in which the person themselves may be realizing that something is going on before other people realize. And then when you get to that MCI stage, close friends, family, maybe people that you work with may start to notice those changes as well. But often we may see that subjective cognitive decline happening before even we see the changes due to MCI. So I just wanted to mention that as well.
Right. And, we're sort of talking about what's happening in the brain and everything else, but imagine what's happening in the hearts of these folks, because it's at times, these periods of time, when people are struggling to maintain a semblance of normalcy. They're scared. They don't want to admit that something's wrong. They're making a valiant effort, wouldn't you say, Melissa, to cover
Absolutely.
up symptoms. And so it's quite a struggle, isn't it?
Absolutely.
So, and it's at that point that we're trying to encourage people to get an assessment and to get early intervention. Thank you, Melissa.
You bet.
So with that, against that backdrop, our goals today are, and I've already done it, to provide that broad definition of dementia, and as a starting point to define Alzheimer's and talk about that. But, I don't really want to spend a lot of time there, because all of you sort of have that baseline knowledge. We know that dementia is a broad umbrella term. It describes any brain impairment that's progressive and degenerative in nature, involving memory, thinking, and judgment. We know that Alzheimer's disease is the most common form of dementing illness. The meat of what we want to talk about today are these other types of dementia, including FTD, Lewy body, and vascular dementia, and to walk away again, as I said, with a little bit more knowledge and more awareness of these types. And they are actually the most common forms of dementia after Alzheimer's today. So, and then we want to do something a little fun today. We want you to take what you learn from the slides and the discussion that we have today and give you a chance to look at a couple of case studies and then apply what you've learned and just try your hand at diagnosing these case studies. So we'll do that in just a little while as well. So I think we're going to kind of skip quickly through these slides and get to those other dementias. So all of you have access to the slides. Melissa shared with you how you can print them off. We know that dementia kills the brain cells as it moves on its slow but steady course throughout the brain. It starts in the hippocampus. In Alzheimer's disease, almost always the hallmark, the beginning symptom, because of the damage starting in the hippocampus, the cellular damage causes short-term memory loss, and then continuing death and malfunction of the neurons causes not only changes in memory, but behavior and just the ability to make good choices and to think clearly. And so challenges with problem solving, planning, familiar tasks at home, etc. Take a look at all of these. These are basically the 10 warning signs. And I think we're all pretty familiar with these, wouldn't you say, Melissa?
Yes, definitely, absolutely.
Absolutely. So, yeah, so, I mean, as we're all, all of us are not only called upon to be workers in the field, but also educators in the community. And so, we tell people that it's not just about memory, but it's also about the changes in language and communication, the ability for our folks to just do routine tasks, our folks have difficulty with the way they process sensory information. So they just don't see the world or experience the world in the same way that we do. And with all the changes in the ability for the cells to communicate with one another and the changes in the brain, you know, obviously behavior in mood are affected, and behavior is no longer a choice, but rather a reaction to all of the changes in what's going on. And I think a lot of you have seen the contrast between what a normal section of brain tissue looks like and a similar view of an Alzheimer brain. If you haven't seen these before, it's very disturbing, because in this section you can see healthy brain tissue that's thriving. You see very, you know, little gaps. Here you see, you know, lots of atrophy and shrinkage of the brain, and, you know, the gaps, as I said, where healthy cells once were thriving, now you see fluid-filled gaps and a lot of severe damage. And here, of course, you're looking at, you know, late to end, this is end stage Alzheimer's. So these slides are difficult to look at, but they really tell the story of the havoc that Alzheimer's wreaks on the brain. And so here we go with the other types of dementia. And you know, really the takeaway here is that each type of dementia has a different cause, a pattern of a progression, symptoms, and life expectancy. And so whereas we think that Alzheimer's disease makes up probably 60 to 70% of the cases, we have Lewy body disease making up 10 to 20% of cases, FTD at 5 to 10%, vascular disease 5 to 10%, and then there's a whole host of other dementias as well. So let's start with Lewy body. And Melissa, I was so disappointed we couldn't have both our webcams, because then I could see you and you could just open your mouth and talk as well, but just chime in, because you're very knowledgeable about all of these disorders.
You bet, I'm here.
What?
I said, you bet, I'm here.
Yeah,
I'm still here, even if you can't see me.
Yeah, so chime in, but you may know, you may recall Lewy body being in the news a lot a couple of years ago when celebrity Robin Williams passed away. He was diagnosed with Lewy body dementia, amongst other, you know, and of course, a lot of people have multiple diagnoses. In fact, you know, it's not uncommon anymore upon autopsy. I was reading this a couple of months ago, for people to be diagnosed definitively with 2 to 3 different types of dementia. They can have, like, say, Alzheimer's disease, vascular dementia, and Lewy body. It's not unusual at all. But anyway, Robin Williams had Lewy body dementia. It is a progressive brain disease like the other dementias. It's not as rare as, you know, is commonly thought. It's the second most common form of neurodegenerative dementia, so it comes second after Alzheimer's disease. And we think it may account for up to 20% of dementia cases in the US. So there's over 1.4 million cases that we know about. And of course, it's underdiagnosed, so that number is probably quite higher, quite a bit higher. And as I just mentioned, it may coexist with Alzheimer's disease. It's probably fairly common. So only 30 to 50% of Lewy body cases are accurately diagnosed, even in dementia centers. So Melissa, do you want to comment on how this is misdiagnosed a lot, or is there anything you want to add here?
Yeah, I mean, I know that in a couple slides we'll talk about the similarities between Lewy body and Alzheimer's disease, and we'll also, I think, on the next slide talk about some of the hallmarks that really do separate it from Alzheimer's disease, like the ones you see here that we'll talk about, those fluctuating levels of consciousness, the hallucinations, and REM sleep behavior disorder. I'd say those stand out to me as being pretty different than the hallmark signs of Alzheimer's we see, which is that short-term memory that we typically see first, and that's not typically maybe the first symptom that we would see with the Lewy body dementia.
Right, right. But the sad thing is that our healthcare practitioners are not as well versed in these disorders as one would hope. And so, we have a special support group that's just for people that are caring for someone with Lewy body or frontal temporal dementia. Not because those two have that much in common, but just because the caregiving burden is more severe. And so the caregivers are drawn together for that reason. And all of them sort of tell the tale of going from, practitioner to practitioner seeking a diagnosis, or even like going to psychiatrists and trying to get an accurate diagnosis. And so, yeah, so many of them have, it took them years to get the diagnosis. So, yeah, Melissa mentioned a few of these features. And you know what? I'll just say this. It looks like Parkinson's. And this can be a sign, like if you're working in a care community and you're seeing a resident there with dementia who's got rigidity and that shuffling gait, and they're a fall risk, they tend to fall, that sort of thing. It sort of looks, it's got those Parkinsonian features, but then that sleep disorder, home caregivers tell us that they can't sleep with their spouses because they're getting beat up. It's not the person's fault, but they're acting out their dreams and thrashing in bed at night and pushing and shoving and all manner. It's just this really wild sleep disorder. And then there's fluctuations in their functioning, in their lucidity. So this is very stressful and hurtful for their caregivers because they, all of a sudden it's like they're okay again. And that might go on for a day or two. It's like, maybe I was wrong. Maybe they are okay. So this fluctuations in lucidity where they seem like they're better and then they descend again. But one of the real marked signs is hallucinations. And they're visual hallucinations, and they typically see, and I've been hearing about this for years, they see people and they see animals, the children a lot of times. I remember having a woman call me, a patient calling me years ago, and she said, and she really didn't have, memory loss was not her presenting symptom. And she said, I am calling you because I see children in my house, and I know they're not real, but how can I deal with the lack of privacy? Tell me how I can deal with that. I mean, it was so tough. It was so tough to help her and to know what the right thing to say, because she just felt like that was her problem. It was the lack of privacy. And I remember this was years ago, and I remember kind of stammering and saying, try to think of it as like a projector. In the olden days, we had the slide projectors. I said, your brain is like a slide projector, and it's just projecting images, into your home, and think of them as like, it's like that. And I was just like, I felt so inadequate, and anyway, so these are some of the features, those detailed visual hallucinations. They usually can't hear anything. They're not usually auditory, but it looks like Parkinson's, and they've got all of those features, and then all of these behavioral issues as well. And then Melissa, you and I were watching a Teepa Snow video, and she was talking a lot about the antipsychotics. Yes. And the problems with medications. And this is like the huge red flag, why it's so important to know when a person has Lewy body, right?
Right. Absolutely. Those drugs can be very dangerous for individuals, the traditional antipsychotic meds that are sometimes prescribed for people with Alzheimer's and other dementias for, quote, behavioral symptoms can have very adverse effects for individuals with Lewy body.
Right. So if you've got this guy with, you know, or woman with Lewy body in your care community, and they've got this sleep disorder and they're crashing around and everything, and you think, oh, well, you know, maybe we need to just prescribe something to help them sleep, and it's an antipsychotic with a black box warning, that could make things just horribly go wrong, right? So we have to, it's another reason why we really need to know. Of course, here with us at Alzheimer's Orange County, we're always going to advise a social type of intervention before we go to a medical intervention, right? I mean,
absolutely. It's very important. We have one question that I want to address. There's several questions coming in. Thank you all for asking those, and we'll get to those at the end. But there's one particular I thought we would address now, and that is, are hallucinations the same as delusions? And that's a great question, and they're not the same. Hallucinations is really that you're actually imagining that there is something there in front of you that is not there. So like Kim mentioned, that children, I think is pretty common. Pets and children, I've read, is very common hallucination for people with Lewy body, versus a delusion is a type of thinking, right? Something happens, maybe you can't find your purse and you're imagining that somebody stole it. You know, that's a type of paranoia. I don't know, Kim, can you describe a delusion a little bit better than I am right now?
There's an easy way to remember this. Hallucinations are scenes, you see something that's not there, and a delusion is believing something that's not true.
Perfect. You know, I knew you would concisely describe that.
We treat them both the same way. We believe we believe in what they see, and we believe in what they think. So if they have a delusion that someone's there and they're trying to hurt them, then we treat it like you always go for the feeling behind it, right? So if they think someone's there and they're trying to hurt them, then we say, oh my gosh, you must be so frightened. I'm going to find that person and I'm going to make sure they don't hurt you. And if they see something, and we're going to say, oh my gosh, that must be so scary, I'm going to keep you safe. You know, you always respond to the emotion behind what the person is seeing or feeling. It's always about the emotion. We never say, oh, no, there's no one there. Or no, that's not there. Or, no, that's not happening. We always go with the emotion. Yeah, absolutely. Yeah. Okay. Oh, I forgot. I have to change the slide. I got kind of carried away there. Okay. So this is just a little bit more about the REM sleep disorder. And you can read more about that. It's common, it happens. You know, they thrash around, they even fall out of bed or strike the partner. Yep, and it can be an early sign. It can be an early sign when that's happening at home. Additional symptoms, the hallucination that we talked about. And then that, okay, the transient and unexplained unresponsiveness. And I think what they're talking about there is sort of the mask effect that you see in Parkinson's. I know those of you that have worked with Parkinsonian patients, you know, they sort of have that blunt affect, that mask. You see that in Lewy body. And then, yeah, the delusions, illusions, mood disorders, visual impairment, like depth perception, object orientation, trying to put the glass on the table and missing. And of course, that depth perception, what's that going to cause? Problems with falling and, you know, motor skills, those kinds of things. Yeah. All right, so how does it look like AD? That progressive memory loss, although you remember I said we're going to see some fluctuations there, or maybe it's not the presenting symptom. Decreased judgment and insight, lack of initiative, disorientation to time and place, difficulty with language. So, you know, that sounds very AD-ish, right? But now we've learned the things that are very different. So let's move on to FTD, which again is, you know, makes up about 5 to 10% of all dementias. It's the third leading type of dementia. And you know, this is one where, you know, people get sent to the psychiatrist a lot because it actually doesn't present with memory loss initially. It presents with aberrant behavior, personality changes, emotional disturbances, and it happens in, you know, with a younger onset. So it's younger people. So again, you know, you got like say someone in their 50s and all of a sudden, you know, and I'll tell you about this client. This is an actual story. I mean, he was at a party, an employee party, and he started drinking out of the punch bowl at the party. And it wasn't alcoholic, you know, it wasn't like an alcohol thing. He just was thirsty and he leaned over and started drinking, just, you know, totally out of the blue. So it's frequently misdiagnosed as something psychiatric, or maybe they think it's mental, you know, maybe they think it is Alzheimer's. But there's problems in the neuropsych testing around attention and inhibition and executive functioning and language. And you'll see that these are all frontal lobe functions, as opposed to, remember we talked about hippocampus and Alzheimer's. That's where the damage starts, and that's where short-term memory is affected. So this is about stuff going on up here. I'm so scientific, right? Stuff going on up here, as opposed to early memory loss. So it's very different, and it looks very different. It's damage to the frontal lobes. So just, you go ahead and look at these symptoms: poor impulse control, apathy, poor judgment. We've had clients who, you know, disrobed in public, or they became obsessed with internet porn, hypersexual behaviors, overeating, compulsive eating, just really, you know, started going to, you know, I had one that just started going to bars all the time, and, you know, displaying behaviors, just total lack of insight, just very poor social behavior, which of course, just imagine how families would react to that. And so I have to say that in the early days when we were just learning about this, there were so many divorces, and you just, I mean, you can't imagine how spouses just could not understand why their loved ones were behaving in these ways. And it took years to get to the diagnosis. So very, very difficult on marriages and family, just terrible. So cognitive abilities were challenged because of attention problems with planning, organized, prioritizing, all of these things. And again, with the younger onset, a lot of these people were trying to work and they were getting fired. They were breadwinners. In our earliest support groups for these families, we had men that were in their 50s that were fired. They still had young children at home. Very difficult demands on the families. Impaired ability to perform the complex activities of daily living, you know, again, because they were working, driving, all of these things. So a lot of problems with executive functioning.
Kim, I want to jump in real fast. There was a question about what is executive functioning. So I just want to expand on that for a second. And the way that someone described it to me once, which simplified it a lot, and I really liked it, was executive functioning is our ability to manage our lives. Basically, any planning that takes place, you know, from a simple action to, you know, going shopping to the store, the ability to plan an action and then carry that action out. That's really at the heart of executive functioning. And there's a lot bundled up in there, but that's essentially what it is. And somebody else had mentioned earlier, asking about primary progressive aphasia, which is one of the types. We know that FTD, like dementia, like Lewy body dementia, these are all umbrella terms, right? So there's a lot of different variants, and we're not going to get too much into the weeds here, but I'll just mention that for FTD, the behavioral variant, which we've been talking about quite a bit, is the most common type of frontotemporal dementia. So that we see that disinhibition, that apathy, compulsive behaviors, maybe a lack of insight about what's going on with oneself. So behavioral accounts for about half, at least half of all cases. And then there's something called primary progressive aphasia, or PPA, which is the next common subtype of FTD. And so that's really more of a language problem. So there's a gradual impairment in language. That's typically the first symptom that you would see. And then again, there's at least 3 types of PPA. So we could talk about this for a long time. I want to mention, I can't remember if you had mentioned the 60 Minutes episode that was on FTD several months ago. I'm sure it's been more than that now. But that was a very good episode. It had video clips of a couple of people, one with the behavioral variant, one with that primary progressive aphasia. And some of those clips are available on YouTube if you search like 60 Minutes frontotemporal dementia. And I think that will help clarify for a lot of people the typical symptoms that you would see in these different types of FTD.
Absolutely, that's a great resource. And I will say that, aphasia it's just a word that talks about communication problems, and that really, because communication is frontal, all people with FTD have communication problems sooner than Alzheimer people do. I mean, all people with dementia have problems with language sooner or later, but it's sooner with FTD, and that's very general. My explanation is very general, but people with PPE, they can have problems like right away. They become mute in many cases pretty soon, and so that's an added struggle. But yeah, all of these, oh my gosh, there's so many subtypes of dementia. Thank you so much, Melissa, for stepping in with that.
You bet.
And the executive functioning, I don't know why we say that, because it makes it seem like, oh, they can no longer be a CEO at a corporation. Really, it's just, again, about being able to just complete a task from beginning to end, right? It's sequencing. Yeah. All right, vascular dementia. And there's several subtypes of this as well, but we're just going to kind of talk about it in broad terms. And this here, we're talking about, a problem an event or a series of events that have reduced the blood flow to the brain, which has deprived the cells of, vital nutrients, etc., oxygen. So sometimes people have a major stroke. Sometimes people have multiple little strokes, which we used to call infarct, and we used to call this multi-infarct dementia. And sometimes people have a chronic problem with low blood flow, which is known also as vascular insufficiency. But in any event, we see differences often in the progression, whereas Alzheimer's disease is sort of a slow, gradual decline over the years. We can often see a stepwise progression. I don't know if you can see this, but we'll see people that have a stroke and then they kind of plateau, and then they have another event and then they plateau again. So there's a lot of variation in this, but I actually have also clients who had a stroke and became impaired, and now they haven't had any more events, and so they've been on a plateau for a very long time. So there's a lot of variation in this, and again, a lot of different subtypes. But I think the important thing is to, just sort of know that this is different than Alzheimer's disease, because it's not a case of brain cells progressively dying throughout the brain like we see in Alzheimer's disease, but rather just events that occur that are attacks on the brain that are caused by a lack of blood flow to the brain. Would you add to that, Melissa?
I'm sorry, I was responding to a couple of questions here, so I don't want to jump in on that.
Anything you want to throw in about, we don't have a lot, I didn't add a lot of information about vascular dementia in the slides here. I really wanted to focus kind of on FTD and Lewy body, but is there anything you want to add about vascular dementia before we go in?
No, just maybe underscoring that it is rare for it to occur by itself. There are a couple questions to that effect. Different statistics out there about it being the second most common type. But for it to occur purely on its own, researchers and clinicians are saying more and more that that's not very common. It's more common that it would appear in a form of mixed dementia with an
Right.
Alzheimer's or another type of dementia. So it's not that vascular dementia is rare, but it's rare for that to be the only type of dementia
Got
that
it.
we're having.
Okay. Okay. All right. So everybody kind of take note here, because in just a few minutes, we're going to ask you to try your hand at diagnosing some cases. And I think that,
I'm so sorry to interrupt, but we've had a couple questions about the poll questions, because typically we do have a poll question by now, and I want to assure you all that you have not missed them. We're doing something a little different today, where they're going to be stacked towards the end. So thank you all for your questions about them. It shows that you are indeed with us and paying attention. So fear not, we have not done them yet.
And by the way, we should mention that some of you had difficulty with the poll questions last time, not being functional. If for any reason you have trouble again this time, just put your answer in the chat box, okay? Just wanted to mention that. So we have a chart here, and it goes on to a couple different slides, but take a look here. This is really helpful. It's just kind of eyeball it. It's a thumbnail sketch of how the three compare: AD, Lewy body, and FTD. So just let's just look at it together before we do our cases. So just sort of take a look at how the age of onset is different with these three, and how the earliest signs vary. So you see different age of onset. You see with AD that, the first sign you're looking for is memory loss, but with Lewy body, you're kind of looking for it to seem like Parkinson's. And then the first sign you look for FTD, like I was explaining, is personality changes, right? And then even the cognitive effects are different, because remember I said with Lewy body, sometimes it's not always memory, and sometimes that fluctuates. And FTD, you're going to see more language impairments. So you begin to see that maybe at the beginning of this discussion, you thought they were all sort of similar, but hopefully by this time you're seeing that there's a lot of differences. So with language, in AD, they're losing the words. But with FTD, as we just said, there's a lot of aphasia, and so on. So just sort of take a look. And then the social skills. Remember we said with Alzheimer's in the beginning, they're really trying to fight to preserve everything, and they don't want anybody to know about their symptoms. Remember we said that about, especially when they have MCI and even early stage. But with FTD, it's like, they have no impulse control, and they might be standing out there taking their clothes off, and they're like, what's everybody looking at me for? So just lots of different, things that really make these diseases very, very diverse. And so you don't have to be an expert, but now you've got a little guide in these slides, and you've had some exposure. And I'm sure that many of you have seen and cared for some of these clients. And I know when we're all online together like this, we all have varying levels of expertise. And some of you maybe, know a lot about this, and some of us may be just hearing about it for the first time. But Dr. Clave and I wanted you to have an opportunity to kind of try your hand at diagnosing. So let's start with Jim's story. So do you want to do this one?
Sure, I'll read it out.
Okay.
All right, Jim's story. Jim was a 76-year-old gentleman who was admitted to a psychiatric hospital after being arrested for shooting his rifle at, quote, space aliens on his front yard. His wife said he had been seeing people for several months that she said were not real. And so when he was evaluated, he was found to have detailed visual hallucinations, memory impairment and dementia, symptoms of Parkinson's disease, fluctuation in consciousness or intermittent intermittent delirium, as well as severe sleep disturbances in the form of REM sleep behavior disorder. And so we'll go ahead and launch that poll. Got a little bit of a smattering, but most of you chose Lewy body, which is indeed the correct diagnosis. Very well done.
Great job. All right, let's try another one. Let's see. All right, this is Pete's story. In 1998, at age 50, he began showing definite personality and behavior changes, according to his wife. He became selfish and self-centered. He had a lack of empathy and emotion. He became very impulsive in his behavior, and he had some real quirky habits, poor judgment, poor impulse control, and extreme apathy. In 2006, he came home from work. He had a really great job that he'd had for over 16 years with a 6-page letter explaining why he was being fired. The letter described all the things that he had not been doing on his job. He was displaying severe apathy. All right, so what do you think?
Very nice. Well done.
So Ruben, a 57-year-old gentleman, suffered a ruptured aneurysm. And in his, you know what, I'm having trouble reading this whole thing. I'm in the way. My control panel's in the way. Suffered a ruptured aneurysm in his right aortic hemisphere in early 2013. He was in a coma for 21 days. He wasn't expected to survive. He did eventually regain consciousness. And he slowly regained his ability to walk, talk, and care for himself and drive. Neuropsychological testing showed deficits in memory, attention span, speed of information processing, verbal fluency, and executive functioning. While his functioning at home was not that impaired, he was no longer able to return to his job as the head of a very successful accounting firm that he founded. In fact, he was no longer able to hold any type of job. He is now enjoying his retirement, but needs some assistance. He has not declined or improved cognitively, so he's kind of just on a plateau. What does he have? What do you think?
Very nice.
So we're going to wrap up now. I just think that we put in one slide about just a reminder about communication, and this sort of maps back to what I was saying about we want to try social interventions before before we use medication in intervening in behavioral issues. Because a lot of these dementias, a lot of the medications have black box warnings. And so when we're working particularly with people with FDD, you can see that they have an inability to follow verbal directions. So we want to use nonverbal communication. We use cueing and prompting. We don't want to argue. We don't correct. As I said earlier, we listen for the emotions behind the issue that's going on, and we respond to that. Principles of treating clients with respect. We know how our clients like to be addressed. We always ask permission before we do things to our clients. We know that all behavior has meaning. And we know that whatever they do, they are forgiven, because if they were able to control their behavior, they wouldn't have these diagnoses. So we do a lot of education around these issues. Melissa is doing education for family caregivers, but I'm sure that she would invite you to join her on Facebook Live on most Tuesdays at 10 o'clock for issues of importance, not only to families, but also to professionals. And we are excited that you were here with us today. And I was happy to be your speaker today and happy to be with all of you as always. So thank you for your attention to this topic, and I'll turn it back over to Melissa for questions.
Awesome. Thank you. Yes, we have lots of questions and they're interspersed with answers to the poll questions. So I'm going to parse those out. But
Okay.
I do want to thank our sponsors one more time, Chatterton and Associates, the Wealth Management Team, O'Connor Mortuary, Care Choices Hospice and Palliative Services, and Caring Companions at Home. We could not do it without their support. And so we are so thankful. So let's get to a few of these questions here while we have a few minutes. Bear with me as I kind of parse through these a little bit. So there was one question here from someone who said, I have a 69-year-old client, male, who's been diagnosed with dementia. Lately, he's been telling us stories of, quote, escaping from the assisted living facility out the window and being gone for days. No idea where he was, but he thinks he took a taxi. Does that sound like Lewy body? And I'll weigh in first here. I'm assuming, so this is that he's telling you this, but this is not actually happening. And I would not say that on the surface that is a symptom alone that I would closely associate with Lewy body. I think what we talked about before, that kind of delusions, believing something that isn't true, that can be common in Alzheimer's as well. And the way that I've heard it phrased before, and I like to think of it, is sometimes it's an old memory in the wrong place. And so maybe he's thinking of something else that happened or similar to that, and then trying to make sense of it. And so telling a story that kind of then weaves in what he's been thinking about with something that could plausibly happen in his situation. That's kind of what I would think on the surface without knowing any more about that situation. Do you have anything else that you might add, Kim?
That's fabulous, Melissa. And I would just validate it. I would, I mean,
Absolutely.
He's telling you a story, and rather than say, well, are you sure that really happened? Just validate it and listen. Be a good listener.
Right.
And keep an eye on it in case it's true.
Yes, absolutely. Excuse me. There's another question about, my mom was diagnosed with MCI about 7 years ago. Are neurologists the ones that diagnose different types of dementia, like Lewy body? So do you want to talk a little bit about getting a diagnosis and where people might seek out a diagnosis?
Right. Okay. Well, neurologists are the ones that should be able to give a differential diagnosis. And neurologist should see your neurologist should see your mother every year and repeat her baseline testing to determine if she's still MCI, right? Melissa, is that what the question was, that she was MCI?
Said she had been diagnosed with MCI several years ago, and just asking about, is the neurologist the one that would give a diagnosis? And a differential diagnosis, as you mentioned.
Right, absolutely. And so we give referrals to neurologists at Alzheimer's Orange County, and we cannot make recommendations. We can't know about the level of expertise for all neurologists. I can't say with a surety that all of them are able to make a differential diagnosis. That's my hope. We vet the ones that we have on our list, but you as a consumer have to ask these questions to, and be knowledgeable yourself. And Melissa, by all means, say more. We have diagnostic clinics here in Orange County. We're rich in that regard, those resources. I would take my loved one to a diagnostic clinic and just be really certain in that way if I suspected that they had one of these dementias. A community physician just may not be equipped enough to make that call.
Absolutely. And I would, again, underscore, please call our helpline for referral lists of neurologists, neuropsychologists, diagnostic centers in Orange County, and we could provide that information for you as well. Lots of questions and not too much time. So I do want to say that if you have a question that doesn't get answered, we will try our best to email you with a response. Kim and I will sort through these and get back to you. So don't fret if we don't address it. I'm trying to find some that are kind of common groupings. We'll just stay on a couple minutes here. But I thought this one was really important. It's, how does schizophrenia differ from Lewy body dementia? And I've heard our friend that we mentioned before, Dr. Papard, talk about this a little bit in terms of misdiagnosing patients when they come into the hospital. So if you look at schizophrenia, there's a lot of similarities, right? You have the hallucinations and delusions and things of that nature, but that is diagnosed in young people, right? So teenagers, early 20s, very rare for it to be diagnosed in anyone over the age of 45. And so if someone's getting that diagnosis late in life, that's something that should definitely be looked at and addressed. That's not common for that to just appear in late life at all. So,
and Lewy body has distinct pathology. I mean, upon autopsy, there are substances like the plaques and tangles that we see in Alzheimer's. They have distinct pathology that make it very different. I mean, just clinically as well as, I mean, they're very different. Yeah.
Absolutely. One question here, this person says her husband was diagnosed with FTD in 2012, so a while ago. He was exhibiting symptoms even farther beyond that in 2005. Thought it was depression, maybe MCI. And she says, really nothing has changed drastically over the past 8 years. And is this normal to go on so long without any major changes? And I would say that typically, you're going to see that slow, steady decline. But there are cases, there is a range that can last 2 to 20 years, they say is a range, for many types of dementia. More common timeline being about 8 to 10 years from diagnosis to end of life. But, you've met one person with dementia, you've met one person with dementia is the old adage. And so maybe not average, not typical, but not unheard of is what I would kind of say to that.
Right. And I mean, his predominant symptom is apathy, and he's just sort of, I mean, you describe him as quiet and passive. I mean, a lot of FTD people have extreme behaviors, but everybody's different. And so he's, again, he's just, you met one person with dementia, you met just one person, like Melissa said. Yeah,
absolutely. So quite a few questions about some kind of behavioral issues and how to deal with those. And so I just maybe we should
stop this for a second, Melissa, because I feel like we were inadequate in answering this last question.
Oh, okay.
I want to encourage you to become a member of our FTD Lewy Body support group, because it's meeting virtually now on Zoom, and you can call our helpline and get involved in that group, because you deserve a wider audience of other caregivers to address your question to. I want you to talk to the other caregivers rather than to us about that, okay?
Absolutely, yes. If we haven't plugged our support groups enough, we have plenty of Zoom support groups. We really invite you to check them out on our website, alzoc.org. There's plenty of days and times, and we would really invite you to contact us, and then we could plug you into support group. We love being able to connect that way, especially since we can't connect in person these days, which is so heartbreaking. But it's not half bad on Zoom. We can still see each other's faces, and so we can
connect that way. And especially for her FTD needs. Yeah, thank you.
Right.
Thanks, Melissa.
So maybe we can wrap up here with just briefly talking about how to help our friends and our loved ones experiencing dementia. And Kim, you've talked about it a number of times this webinar, really validating what they're feeling, right? Trying to understand as an individual, their needs, their preferences, their likes. So much of what we talk about as, quote, managing or controlling behavior, we should really be looking at as a framework of how are we improving well-being for this person? How are we being proactive and preventative and eliminating a lot of those triggers that we see, rather than always being on the responding end, right? And I think just having that shift in mentality is so important, no matter the type of dementia, right? There's lots of differences in these types of dementias, but a lot of the common threads they have is that at some point we're going to experience, this person is experiencing the world in a different way, right? They're changing interpretation of it. And so they're going to respond in different ways that we haven't seen them respond. And we talk about all behavior is communication. I think if you walk away with anything, please just walk away with that, that we should really be trying to figure out why a person is saying or acting a certain way, and how can we kind of change our approach and the environment to help manage that. And so do you want to say any last words about that, Kim?
Yeah, I mean, all we're trying to do is keep people safe and have them feel loved, and be as person-centered as we can. And particularly with these other dementias, where I feel like when we're talking to families who are coping with these other dementias, they've got an additional layer of burden and they need an additional layer of support. And so we're here for you. We care about you, and you know, just know that, and please reach out to us, and we'll do everything we can to help support you. And don't worry about being perfect.
Oh boy, yeah, that would be a high bar.
Because really, you know, as Melissa was saying, you know, and we've been trying to say throughout the course of this discussion, there's so much distortion in these illnesses that really just making people feel safe and loved, I think, is key. I mean, we're always talking about all the activities that we need to be doing with them and this and that, but if we can just make people feel safe and loved, I think that's really the most important thing. And
100% agree. Thank you so
yeah.
much, Kim. Please join us next month for our webinar, which will be on July 14th at 11:30, and it's going to be on the impact of Alzheimer's disease on swallowing. We have a speech language pathologist who will be giving that webinar, and we're very excited about that. It's going to be a very, very informative and interesting topic, and so we invite you back with us. Again, visit our website, call our helpline, please connect with us. We appreciate you all so much, and we hope that you stay well and stay safe, and we can't wait to see you all again. Thanks, Kim.
Bye-bye, everyone.
Bye-bye.